John, I'd like to thank you and the organizers for a chance to present a little bit what we're doing in the Department of Oncology as well as the Department of Surgery as it relates to breast cancer. You can see the title of our talk here, Individualizing Breast Cancer Care, Genomic Sequencing, and Mouse Avatars as a Tool to Accelerate Drug Development. So the use of chemotherapy after breast cancer surgery has really been a relative success. The idea here is that in many different tumors, after you remove the primary tumor, that there still remains a substantial risk for relapse. And that relapse, if it occurs in distant organs, of course, can be fatal. This was recognized many years ago, and a very seminal paper in a study that was done actually started enrolling patients in the early 1970s, was a study by Dr. Bonadonna from Italy, where they took patients who had a relatively high risk of recurrence after their breast cancer surgery. That is, these women were known to have positive lymph nodes. And after surgery, these women were given 3 chemotherapy drugs, or a group of patients actually received no treatment, which was the standard of care. And what you're seeing on this curve, what we call a Kaplan-Meier curve, is the risk of recurrence or death actually out at 20 years. And these data actually were published in the New England Journal of Medicine within the last 10 years. You can see that the patients that received the 3-drug combination of Cytoxan, methotrexate, and 5-FU did substantially better than those who did not receive chemotherapy. And this was the start of literally a new method of treating patients after surgery to reduce the risk of recurrence. Well, that study was started in 1973, and this study enrolled 319 patients. And I want to fast forward you now to 2012. Here's another trial, this by the NSABP, presented by Dr. Sandra Swain at the most recent American Society Clinical Oncology meeting. And here again, we see the same idea. Women, they've had breast cancer surgery, they were node positive, and they were randomized to receive one of a number of different chemotherapy regimens. In fact, there are 3 arms. But notice here that instead of 319 patients, there's over 4,000 patients enrolled into this clinical trial. And what you see here, interestingly, is out at 5 years, first of all, there was no difference in the clinical outcomes. But notice that at 5 years, patients are actually doing quite well. And in fact, if you look at the risk of recurrence or death at 5 years, it's about 10%. Contrast that to the prior trial, where the risk of recurrence or death at 5 years was about 40 to 50%. So we've reached sort of a, if you will, a plateau. It takes more and more patients and a long period of time to determine and actually to advance drug development. So we asked the question, how could we potentially advance drug development and do it in a more efficient time frame?
So the top part of this slide shows what I call the old model, as Dr. Goetz described, for patients who are usually recently diagnosed with breast cancer, undergo surgery. Me as a surgeon, we feel like as surgeons we cure people of their breast cancer, but as Dr. Goetz quite rightly pointed out, many of those patients then go on to receive chemotherapy, and we then follow those patients for time periods that can be 10, 15 years, and hope that they don't relapse, but understanding that a percentage of them will have some kind of relapse of their breast cancer. The new model is what's called neoadjuvant chemotherapy, and this is really the way that increasingly we're beginning to treat patients these days. If we know when we meet a patient recently diagnosed with breast cancer that that woman is likely to receive chemotherapy after surgery, then the new model is to actually give that chemotherapy before surgery. And this is a real paradigm shift, both for the patients and for the physicians, but is really an exciting step forward. For the individual patient, it means that we are able to follow their individual tumor and how their tumor responds to the chemotherapy that they're receiving within their veins, and that the individual physicians treating those patients can see how that tumor is responding. And often when you explain it to a patient like that, they're very excited about this approach. The real nice outcome from this is that when we get to the operating room after the patient has completed their chemotherapy, we gain a lot of information. Our golden goal for those patients is to find no residual cancer in the breast or the lymph nodes when we get to the operating room on that final pathology report. But we know that some patients, especially if their tumor has not responded very well to the chemotherapy, will have residual disease either in the breast and or the lymph nodes. Now, the importance of this, as you can see on this slide, is that at that time of surgery, which is within 6 months of initial diagnosis with breast cancer, we have seen how well that individual patient's tumor has responded to the chemotherapy that that patient has received. That's very exciting, but more important than that, the studies, multiple studies now have shown that if you correlate the outcome or the result at surgery, that completely correlates with their overall survival. And so this graph here shows that those patients in the green line, those that achieved a pathological complete response, no evidence of cancer in the lymph nodes or in the breast at surgery, actually have a very good overall survival and a very good disease-free survival. However, those patients that still have any form of residual disease in the breast or the lymph nodes at surgery have a poorer survival. And this is the group of patients that we need to focus on enhancing drug development and having better targets so that we can improve their outcome. And so really moving forward, at 6 months, we can have the information about how patients will do, which used to take us 10, 15 years to see who might relapse, who might have further breast cancer events. This pathway of moving forward with drug development in the neoadjuvant setting has actually been endorsed now with a recent statement in the New England Journal of Medicine, where the FDA came forth and actually stated that pathological complete response is a pathway that we could look for accelerated drug development and drug approval in early stage breast cancer, as it's a very good surrogate endpoint. Now, we know already that not all breast cancers are alike. There are different subtypes of breast cancer, and Dr. Goetz and I believe that there are many, many more different subtypes than what we have already identified. But this slide here, from some work from the German oncology group from Van Minkwitz, shows the different subtypes that have been identified to date. And as you can see in panel B, D, and E, the subgroups that are triple negative or the subgroups that are HER2 positive, we clearly see a very clear definition that those patients that achieve a pathological complete response have a great survival, and those patients that don't achieve a pathological complete response are the area that we need to be targeting and working on improving our drug development for. Now, if we look at subgroups and we look at how can we identify one aspect among the breast cancer subgroups to target for a drug response, how do we know that targeting just a single aspect of a breast cancer will actually help improve outcomes in response to chemotherapy? Well, this was a study published in Journal of Clinical Oncology in the mid-2000s by Aman Bouzdar from MD Anderson Cancer Center. And I have to say, I'm very jealous of him for this work because, as Dr. Goetz nicely pointed out, these days you need about 4,000 patients in 10 to 15 years to show that you've actually made an improvement with this new drug that you've maybe spent years developing. Well, if you can see from this slide, Dr. Bouzdar targeted the HER2 receptor with a drug called trastuzumab, and with a total of 40 patients in 6 months, showed an improvement in pathological complete response from 25% to 66%. This was a huge breakthrough and has now very much impacted our standard of care for these patients. But this is just a slide to describe how we can have smaller number of patients, shorter period of time, and actually impact the future now, rather than working now to improve the future in a couple of decades.
So, as it turns out, the complexity of cancer, as you understand, is really quite profound. And in this particular slide, if you look up at the left-hand corner, you see this specific HER2 receptor tyrosine kinase that was referred to. And in about 10 to 20% of breast cancers, this particular tyrosine kinase is overexpressed or amplified, leading to a change, if you will, in the phenotype of the cancer cell. But what this diagram shows you is that cancer is very complex, and there are multiple different signaling pathways present both at baseline when a patient is diagnosed, as well as changes in these pathways that result from the treatments that we deliver. So in order for us to really accelerate drug development, We need to be able to understand the complexities at the level of the individual cancer cell. Furthermore, and perhaps even more importantly, we need to understand the complexities that occur in response to the treatments that we give. So we think that these are some of the barriers that are present. And to overcome the barriers to drug development, we need to have a clear idea, first of all, what they are, and secondly, how might we come up with a new paradigm. So first of all, as Dr. Boughey mentioned, it would be best if we could assess the tumor response in real time. So the neoadjuvant approach seems to be that idea, 4 months versus 4 years. Second, to be able to assess the genomic complexity. We'll go forward one slide, please. To be able to assess the genomic complexity and the adaptive responses that occur in response to chemotherapy. And here the big issue is the cost of doing this sequencing. This slide here shows you the cost per genome and the so-called idea of Moore's law, and the fact that even 5, 6, 7 years ago, the idea of sequencing the tumor genome was really unthinkable. But now, because of the fact that the technology has really become cost efficient, we are now able to do this on an individual patient, and we're able to do it in a manner that doesn't, if you will, break the bank. But finally, and I think perhaps more importantly, what we'd like to be able to do is once we've assessed that genomic complexity, once we've identified the markers that are potentially associated with resistance, we would like to be able to test them in a patient's tumor that was resistant to chemotherapy. And if you will, if I have a patient that just finished 4 months of chemotherapy and still has a substantial amount of residual disease, if I have identified a new drug target, I would like to be able to assess that. And the idea here is to be able to grow patients' tumors in the so-called xenografts or avatars, and to be able to then assess the response to some of the novel agents that we are identifying from the sequencing. And this is the idea of using an avatar. Here what we do is we take the patient's tumor, the patient undergoes a biopsy, and in real time we inject it into mice. The tumor, once it engrafts, you can see here, this can take anywhere from about 2 to 3 months. Then once that tumor grows, we expand that tumor. We have the ability then to literally perform mouse clinical trials using drugs and novel drug combinations that we have potentially identified from the sequencing. So what is our vision? Our vision is individualized cancer therapy based on genome sequence, both at the host as well as the tumor. We think that breast cancer is an ideal starting point, and that individualized genome sequence guided adaptive therapy literally could be extended to many other cancers.
So taking the neoadjuvant approach, taking our breast cancer patients, that we have many patients that fit in that category, taking the use of genomic sequencing, and having the ability to set up these mouse avatars, these patient-derived xenografts, we're undertaking a study that we so friendlily call BEAUTY, the Breast Cancer Genome Guided Therapy Study. This has been open since March of this year here at Mayo, and we're looking to enroll about 200 patients over a 2-year period. These are patients that we identify from our clinic that have a breast cancer that we anticipate requires treatment with chemotherapy in the neoadjuvant setting. And these patients in this part of the study are still receiving the standard drugs that we know in this day and age work. And we're studying these tumors and these patients' responses to these drugs intensively. Before they start chemotherapy, they have their regular imaging with a breast MRI. We also have a novel functional imaging technique called molecular breast imaging embedded in this study. As Dr. Goetz mentioned, they undergo a biopsy of their tumor, which is a research biopsy, and the tissue from that research biopsy goes off both for the mouse avatars to grow the xenografts and also for genomic sequencing. And we also have a blood sample at baseline to look at the host genome. They then undergo their chemotherapy, standard of care chemotherapy with paclitaxel plus or minus trastuzumab. And they come back halfway through their chemotherapy, once again for some imaging to see how well they've been responding to the chemotherapy, and then another biopsy to look at any changes in the tumor genome as a result of exposure to the paclitaxel chemotherapy. They then complete the final portion of their chemotherapy, which is an anthracycline-based chemotherapy, and again have imaging, MRI and the molecular breast imaging study to look at the response to chemotherapy. They then go to the operating room and we're able to retrieve any residual tissue from surgery, and this tissue is then being taken once again for genomic sequencing and establishing the mouse avatars. So essentially we'll have genetic sequencing information at 3 time points along with the host genome sequencing. Most importantly, we'll have the response to chemotherapy to say how much tumor was remaining in that patient when we got to the operating room, which we know correlates with their outcome. And we can study those patients with the poorest response and look at their tumor in what we see in their genetic sequencing information. Anything we identify from the genetic sequencing information, we can study further in mouse clinical trials. Here's an example of one of our early patients enrolled on the study. This was a 36-year-old female. She palpated a mass in her breast. On MRI, it was about 6.8 centimeters. She had some prominent nodes in her axilla. And when you looked at this tumor pathologically, it was a high-grade aggressive cancer. It had what was called a triple negative phenotype and a very high proliferation rate. So this is a patient that when you see them in the clinic, you worry about these patients, and you really want to do everything you can to improve their outcome. After chemotherapy, she'd had some response, but really not a great response. Her tumor still had about 6 centimeter measurement on MRI as well as MBI. And as I alluded to, she had this triple negative phenotype, which if we look back to our earlier slides, we know that these patients, if they don't achieve a pathological complete response, does predict a poorer outcome. So studying this patient's tumor and the genetic makeup of this tumor, and then further testing any drugs that could identify that could interact with the changes in the genetic sequencing and try those drugs in the mice will be a step forward to bring the best drugs to the individual patient in a real-time fashion.
So as Dr. Boughey mentioned, from these biopsies, both at baseline, during chemotherapy, and after chemotherapy, we're doing multiple different sequencing approaches. One of them is to do exome sequencing, and actually literally within the next few months, as price allows, we will actually be able to do whole genome sequencing. We're also doing tumor RNA-seq to understand the actual RNA expression, that is the readout from these different mutations. We also assess the methylation. As Dr. Boughey said, what makes this really amazing is the fact that we have the patient's baseline or their host genome as well, so we can actually understand what variants are truly novel in that tumor versus what's actually simply was present in the host. And finally, we're also doing phosphoprotein arrays as well to understand the changes in these protein pathways. The xenografts, as mentioned, are performed at baseline and at the time of surgery. And again, the whole idea here is to be able to study novel drugs within tumors that did not respond to our best chemotherapy. So in summary, this individualized cancer therapy based on genomic sequencing, our thoughts are to identify the genetic alterations and pathways that are unique to a patient's breast tumor. And then to go on and to do this in real time in a period that's not extending out to 4 to 5 years, but within a 4-month period. We want to assess the biological significance of these alterations. And to do that, we are establishing collaborations actively with both academia and pharma to be able to test new drugs and new drug combinations on these targets. And finally, we will do this in these mouse models to evaluate the drug efficacy and bring forward the most promising drug combinations. Our goal is genome-guided therapy, and we think the Beauty clinical trial is a step forward to getting us to that point. Thank you.
Judy Boughey, thanks so much.